Whilst on placement, our crew was dispatched to a 1B patient who was allegedly assaulted and stabbed. On arrival, the patient was located on the footpath outside his home with an obvious hemorrhage that was determined to be minimal and was subsequently dressed with an Israeli bandage. The trauma truck, CCP backup, and another ACP crew were automatically dispatched to the scene and arrived shortly after. IV access was established and the patient was administered fentanyl, ondansetron, and IV fluids. The patient was hemodynamically stable throughout assessment and was transported Code 1 to the Royal Brisbane Hospital. Trauma appears to play a considerable role in the pre-hospital patient for QAS, and a systematic prompt response often proves imperative. The management of this particular patient was well outside my scope of knowledge. This was the first major trauma event I had attended, and as such I was not sure what to expect, nor the proper protocol for patient management. The extent of my knowledge included only basic hemorrhage control methods. Because of this, I was unsure how to help my mentors and felt quite useless. When necessary, I organised equipment, packed up the kits, and helped in the loading of the patient. However, I was unsure of the location of some items and thus felt this may have negatively impacted upon the patient. Due to the patient being located on a footpath on the side of the road, the conditions were very different to that of a controlled, clean, and spacious environment of our training rooms, or inside a home even. This presented its own difficulties in patient management and extrication that differed to what I have experienced up until this point. After talking with my mentors after the case, they made me aware of the major trauma considerations for such a patient, which made me think about the said situation and what I would do should a similar case present itself. As a result, I feel I am much more educated and able to help manage a similar situation should it arise. According to the World Health Organization, it is possible to minimize the consequences of serious injury by providing prompt pre-hospital care. Thus, the prompt Code 1 response from our crew, along with the automatic dispatch of the trauma truck and CCP crews, undoubtedly had a marked impact upon the response and treatment of the patient, potentially resulting in an improved outcome. Due to the close proximity of this patient to the Royal Brisbane Hospital, the significant treatment consideration was prompt transport to hospital as more extensive treatment and testing could be completed in a timelier manner in the hospital setting. Had the patient been located further away from hospital, pre-hospital examination and treatment may have been different. The World Health Organization also states that while advanced pre-hospital care undoubtedly is beneficial for some patients, there are instances whereby fast and consistently applied basic cares are often of equal, if not greater, benefit. Similarly, Dr. Rappold, a surgical trauma doctor, researched the scoop and run method versus the stay and play approach, and found that short transport times in more urban environments appears to be the key to more successful patient outcomes. From the perspective of my mentors and the on-scene CCP crews, the patient was obviously deemed to have suffered a major trauma. Due to the visible amount of blood surrounding the patient, I was quite concerned initially, as I'm sure were the other paramedics. However, due to the systematic approach and the experience of the other crews, the patient was quickly determined stable and the situation handled very smoothly. After the case, my mentors proceeded to debrief about what had happened and the major trauma considerations and treatment matrix for such patients. As such, I was able to gain a better understanding on the pre-hospital care considerations for such patients. I now feel I will be more comfortable in helping such a patient in the future and not feeling so helpless. Pai et al. Found that self and peer reflection on a student's clinical practice helps to improve clinical competence. After the case, I also took time to fully familiarise myself with the entire contents of both kits and the location of certain consumables in which I had difficulty locating during the case. The Royal Australian College of General Practitioners states it is imperative that healthcare workers are familiar with their available resources so as to ensure prompt and safe patient care that has optimal benefit. As such, next time I believe I will be better able to assist my colleagues in the management of all patients. Future management of similar clinical presentations would be similar within reason to that of this case due to QAS guidelines and clinical practice procedures. Such a structured approach I found to be imperative towards timely and effective treatment in the patient. Eben states that the effective implementation and guideline adherence in practice leads to improved patient outcomes. Amongst a vast array of other skills I have learnt over the past 6 weeks on placement, this case in particular caused me to reflect on my clinical practice in the care of higher acuity patients and as such, I believe my knowledge and skill base has been significantly built upon since the beginning of my placement.